tachycardiomyopathy, and I'll try to be as quick as possible. Just some illustrative cases. This is a 4-year-old preterm incessant child with incessant tachycardia since birth. As you can see, there is cardiomegaly on the chest X-ray, tachycardia on the ECG and the echo. You can see that there is LV dilatation. Now, the ECG clearly shows a long RP, narrow QRS tachycardia, which could be any one of these following. Either it could be a compensatory sinus tachycardia, or ectopic atrial tachycardia, or inappropriate sinus tachycardia. Now, does inappropriate sinus tachycardia cause tachycardiomyopathy? Yes, we do have case reports, as this particular report shows. And for this patient, I did an EP study and RF ablation. I noticed that the earliest atrial A activation was very near the sinus node, suggesting inappropriate sinus tachycardia. Mapping of the LA was done through a transeptal puncture, which showed an early activation without any early activation at the left side, left atrium. RFA was done on the inferior region of the SA node, and baseline heart rate reduced from 145 to 120. Why was EP study done? It was because of failure of drugs in the first place in this particular patient, and the patient was referred to me for some EP procedure by the pediatric cardiologist. Now, after 2 days, you can see that you have the pre-procedure ECG and the echo on the top, and the bottom you have got the post-procedure ECG. You can clearly see that the rate has reduced. It has become sinus rhythm now with a lower rate, and the LV has reduced in size. So case number 2 is a 2-year-old and 3-month-old female child with congenital eventration of the left diaphragm with associated LSVC to CS. The patient was being followed up by the pediatric cardiologist, but after 6 months, patient presented with a supraventricular tachycardia with a heart rate of 210, blood pressure of 80/60, adenosine, amiodarone, all these did not work in the patient. You can see the ECG showing a narrow QRS tachycardia. Patient was in pulmonary edema. Synchronized DC version was done. Patient went into apnea and bradycardia, had to be intubated, emergency resuscitation, and 2D echo showed an EF of 30% with severe LV dysfunction. The patient was taken up late on a Saturday evening for a EP procedure. At the time of taking in the lab, the QRS has widened, and radio frequency ablation was done. You can see the CS catheter in the LSVC, through the LSVC here, and the ablation catheter taken in the tricuspid annulus. The patient had a atrioventricular reentrant tachycardia, which could be seen that the earliest atrial activity was the CS. However, CS site was targeted, but the tachycardia persisted. Successful ablation was done in the right atrial free wall. After that, the tachycardia was non-inducible, hemodynamics improved. You can see clearly here the tachycardia being terminated as the RF was being given, sending the patient into normal sinus rhythm. This is the ECG after the radio frequency ablation with the normal rhythm. Systolic blood pressure improved to 109/57, urine output improved, and the maintenance dose of amiodarone was continued. The child was extubated and discharged with stable hemodynamics and normal sinus rhythm. And this is an article by Juneja from All India Institute on the management of tachycardiomyopathy. As you can see, most of the patients in this trial, in this particular study, was managed either on amiodarone digitalis or propranolol. Only one of the patient of 10 years was given radiofrequency ablation. Subsequently, Dr. Juneja has done many more ablation cases in children with tachycardiomyopathy. Case number 3 is a 26-year-old marketing executive with single ventricle, left atrioventricular valve atresia, pulmonary atresia, and a patent ductus arteriosus who had a BT shunt in 92 and a fenestrated TCPC, pericardial patch enlargement of the main pulmonary artery and the left pulmonary artery, and at which time the BT shunt was interrupted and the PDA was ligated. He presented to us with these atrial tachycardia with a rapid ventricular response. Echo showed an EF of 25% biventricular dysfunction, and this is the pre-ablation echo showing mitral, AV valve regurgitation. And post-ablation, after 3 months follow-up, the AV valve regurgitation had ceased. This patient was, the ablation was done through the fenestration, as you can see in this particular angiogram picture, the catheter was taken through the hole in the fenestration, which was, I'm sorry, this video is not playing, but the fenestration was somewhere at this point, which was marked by during the angiogram, which was injected here, and subsequently the ablation catheter was taken through a sheath, and as you can see here, the ablation catheter targeting the cavo-tricuspid isthmus, which was on the lower part where the fenestration was. The patient had a successful ablation, had sinus rhythm, and symptoms disappeared, and he was doing well for 2 years. When he came with recurrence, the second ablation was also done. Again, it was successfully terminated. By definition, tachycardia-induced tachycardiomyopathy refers to impairment in left ventricular function secondary to chronic tachycardia, which is partially or completely reversible once the tachyarrhythmia is controlled. The concept of this concept dates back to early 90s. Phillips and Levine were the first to describe in 1949. It occurs in experimental models and in patients with tachyarrhythmia. Tachycardia-induced may follow any type of chronic or frequently recurring paroxysmal tachyarrhythmias. One of the important things which causes myocardial dysfunction is rapid atrial or ventricular rate. Either it could be supraventricular arrhythmias or atrial fibrillation. Microscopic changes occur in this thing with elevated ANP, catecholamines, and plasma renin activity, and gross changes which you can see morphologically there is cardiac chamber dilatation, in increased end systolic and end diastolic volume, isolated RV dysfunction, giving rise to a spheroid left ventricular geometry with decreased left ventricular wall thickness. All these causes cardiomyopathy and severe left ventricular dysfunction. If you look at all the causes, there are supraventricular and the permanent form of junctional reciprocating tachycardia, which invariably leads to tachycardiomyopathy. But one should not forget atrial tachycardia, which is another common cause which leads to, because atrial tachycardia are very resistant to pharmacological treatment. Most of them, you find that the atrial ventricular rate will be very high and do not respond to your commonly used drugs, and invariably the patient can go in for tachycardiomyopathy. Not to forget atrial fibrillation, the commonest arrhythmia which we all face. Most of the time the dysfunction could be a tachycardiomyopathy due to the fast ventricular response. Again, the other problem with the atrial fibrillation is of course stroke due to embolia. Ventricular causes are known, but they are much less common compared to the atrial causes. What is the reason why tachycardiomyopathy occurs is because there is a depletion of the ATP stores within the ribosomes of the mitochondria, and this is what leads to the LV dysfunction. The recovery of ventricular function after termination or control of tachyarrhythmia is extremely variable. Recovery may be complete, may be partial, or not at all. The greatest improvement in LV function generally occurs after the first month of termination or control of tachyarrhythmia. This is followed by a slower improvement that reaches its maximum after 6 to 8 months. Recovery of LV function after conversion to sinus rhythm or heart rate control resembles the time course of recovery of LV dysfunction when you see in what you see in patients with a hibernatic myocardium after revascularization, and we even take up to 1 year. Recovery of LV function is substantially greater in patients with profoundly depressed left ventricular function at initial. So ladies and gentlemen, in conclusion, I would like to state that tachycardiomyopathy is a rare but potentially curable form of dilated cardiomyopathy, should be considered in all patients whose systolic dysfunction is diagnosed subsequent to or concomitant with atrial fibrillation or chronic tachyarrhythmia. Suspicion of this entity, mind you, suspicion is the key to diagnosing this condition. Careful history taking and fixing the association of tachycardia at the beginning of the disease is a pointer to the diagnosis. Thank you for your patient listening.